Hi everyone, welcome to NEET Unacademy. Crack all NEET PG exams with us. Where you have top educators, quality content, and a great learning experience. So, guys, let's crack NEET PG. A little about me. I've done my MBBS from Father Muller Medical College, Mangalore. MD in Anesthesiology from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesiology. I have been working and teaching in Bangalore for the past 2.5 years. So guys, let's crack NEET PG. My topic for today will be neuromuscular blocking drugs, and in that the neuromuscular blocking drugs are divided into the depolarizing and the non-depolarizing drugs. So I'll be dealing with the depolarizing drug, which is succinylcholine. The non-depolarizing drug, I'll be taking a separate class on it. So today will just be the depolarizing drug or agonist drug, succinylcholine. So guys, Unacademy is India's largest learning platform which will help you crack NEET PG. You can get plus subscriptions and access unlimited live and recorded courses from India's best educators. So guys, you'll need to hurry and get your subscription. So what will you get out of Unacademy? So like I said, there will be daily live classes. You can chat with your educator, engage in discussions, ask any doubts, and clear polls all while the class is going on. So, like when you go for these coaching classes, it's a huge class. There are a lot of students in the class, and generally, it's a very large number. It's not a small class, so it's very difficult to clear your doubts one and one. It's very difficult to clear your doubts then and there. But what happens with Unacademy, you can chat with your educator while the class is going on. So the educator will tell you whether you send your doubts during the class or at the end of the class. And you can, your doubts, there are classes where you can actually clear your doubts. So it's all covered. It's a one-on-one experience for you all. There are structured courses. All our courses are structured in line with the exam syllabus to help you best prepare for it. So there are top experienced educators who put in their best effort. Their classes are structured and it is according to the exam syllabus. They research a lot and help you all get the best experience so that you all can crack NEET PG. Now there are live tests and quizzes which help you evaluate your preparation with our regular mock tests, quizzes, and you can get detailed analysis on your performance heads. So in between classes, you'll have tests, you'll have quizzes. So as such, it's a very structured manner. It's in a very structured manner. So it helps you all analyze where you all stand, how you all are doing, how you all are coping. And of course, you all have unlimited access. One subscription gets you access to all our live and recorded courses to watch from the comfort of any of your devices from home or anywhere, wherever you are. So it is just one subscription and you can access all live and as well as recorded courses from the comfort while you're at home. So with coaching classes, what happens is you have to travel there. You waste your time. It is a waste of time to travel there. It is a waste of your energy getting there. By the time you get there, you're exhausted. Then by the time you settle down, concentrate. But here you can take it from the comfort of your home when you want. The classes are recorded too, so you can fall back once you subscribe or to those classes. The material is prepared. It's all there for you all to prepare. Plus, you all can you all can fall back to your material, so you all can, and of course, you all can always clear your doubts at any point of time. These are some of our top educators. Dr. Nikita Nanwani. She's a NEET PG mentor for radiology as well as mnemonics and concept focusing. on must-know topics encompassing all subjects. Dr. Mohammad Azam, Devish Mishra, and Dr. Preeti Sharma. So these are the courses offered. So as you can see, there are a wide variety of about 19 courses. So these are all covered for your NEET PG under Unacademy. These are some of the ongoing courses in our platform. As you can see, GI course, practice surgery for AIMS, neurophysiology of the motor system, cardiovascular thoracic surgery, a capsule on the larynx, respiratory system, pathology. So guys, coming to the subscription right now. So as you can see, there are 5 types of subscriptions, but I would highly recommend that you all go for the 12 and the 24-month subscription. So as you can see, the 12-month subscription, now one NEET PG is a tough exam. It requires a lot of preparation. 1 to 6 months is really, you're cutting it very fine trying to cover 19 subjects. So 12 months gives you time to prepare. You can prepare in detail, and hence, and it is more economical too for y'all, because after 6 months you all will have to subscribe again, pay again. But with a 12-month subscription, you are paying once for all for 12 months, and you can access all the courses that are offered to you on this platform. So guys, if you all use my code, as you can see, SASHA, you all will get a 10% discount. So use my code, get your 10% discount, and subscribe as quickly as possible for this 12-month course. Also, coming to the 24-month subscription, like I said again, not everyone can clear in 12 months. In 1 year, it's not easy to clear in your first attempt. I'm sorry, not 12 months. It's not easy to always clear on your first attempt. Of course you can, but if you want to give yourself more time, take the 24-month subscription. That is also a really good subscription, quite frankly. 1 to 6 months is too short a time to cover 19 subjects. It's a tough preparation. It's a tough time for you all. So 24 months, 12 months is a really good deal. So again, 24 months, use my code SASHA, and again you all can avail a 10% discount. So guys, subscribe, use the code SASHA, get your discounts, and start your preparations, and let us help you all. So coming to my class for today, neuromuscular blocking drugs, succinylcholine. I'll be covering succinylcholine. So by definition, neuromuscular blocking drugs principally act, neuromuscular blocking drugs principally act by interrupting the transmission of nerve impulses at the neuromuscular junction. So as you all can see, it principally acts by interrupting nerve impulses at the neuromuscular junction. So these drugs are basically used in anesthesia for surgical relaxation, for tracheal intubations. It is to provide, basically it is very important, these are very important drugs to provide a field of relaxation for the surgeon and help him, which helps him or her operate in a free manner. The South American arrow poisons or cuirass. Cuirass was known to man for a long time in the form of arrow poison used by the tribesmen to hunt animals. This cuirass is basically an alkaloid from the plant Chondrodendron tomentosum. So cuirass was the first led to the discovery of these neuromuscular drugs because it was used in arrow poisons, and it is an alkaloid which is obtained from the plant Chondrodendron tomentosum. Now coming to the classification of the neuromuscular blocking drugs. So depending on the mechanism of action and duration, these drugs are classified as depolarizers and non-depolarizers. So depolarizers basically mimic the action of acetylcholine. So now acetylcholine choline. This is the main neurotransmitter at the neuromuscular junction. Okay, it is synthesized uh, by the combination of acetyl and choline. Okay, and it is stored in tiny vesicles. It is stored in tiny vesicles in the nerve. Okay, and whenever an impulse activates the nerve, impulse is transmitted to the nerve, the calcium channels in the nerve will open. These are voltage gated, so hence when there is an impulse, the voltage gated calcium channels open, there is influx of calcium, which leads to release of this acetylcholine from the vesicles into the synaptic cleft. From the synaptic cleft, this will go and bind to the acetylcholine receptors, the nicotinic acetylcholine receptors, which are located on the muscle. Yeah. So now coming to these drugs, so depolarizers basically mimic the action of acetylcholine. That is, they act like acetylcholine. So when acetylcholine binds to the acetylcholine receptors, it leads to again opening of there will be a conformational change in the acetylcholine receptor, which will lead to opening of the acetylcholine receptor, and there will be influx of sodium and calcium and efflux of potassium. Okay, and this creates a threshold potential at the junctional membrane, that is where the receptor is located, thus depolarizing the junctional membrane. This depolarizes the surrounding membrane, opening sodium channels. So these sodium channels are also located at the junctional membrane. So basically the neuromuscular junction on the muscle side is thrown into many folds. Okay, this is the muscle and this is your nerve. So the acetylcholine receptors are located here. Acetylcholine will come and bind to these receptors. Nicotinic acetylcholine receptors cause a conformational change, influx of sodium, calcium, efflux of potassium, leading to depolarization, the sodium channels are located within the cleft. The acetylcholine receptors are on the shoulder of the clefts, and these sodium channels located within the clefts. The depolarization spreads, the sodium channels to open, there is again influx of sodium, and this will lead to and hence there will be again a potential created, which gets transmitted further down the muscle, leading to contraction. Okay. So depolarizers mimics the action of acetylcholine, that is, they bind to the acetylcholine receptors and they lead to a conformational change, and they actually initially lead to muscle contraction followed by paralysis. How this occurs, I will explain to you all further. Now the two type of depolarizers are dexamethasone and succinylcholine, which is succinylcholine. Now the depolarizers act as antagonists. Okay? They act as antagonists, that is, they compete with acetylcholine to bind to the acetylcholine receptors. So that will be a different class. Depolarizers, on the other hand, mimic the action. They act like acetylcholine. Now, the classification based on the mechanism and duration of action. So, short acting is succinylcholine, that is a depolarizing drug, and non-depolarizing has been classified as short acting, intermediate acting, and long acting. Short acting is gantancurium, mivacurium, and intermediate acting is atracurium, cisatracurium, becuronium, rocuronium. So long acting is again pancuronium, pipocuronium, doxacurium. So now these I will be dealing with, these three I will be dealing with in my next class. Right now we will focus on succinylcholine. Now coming to succinylcholine. Succinylcholine or succinylcholine diacetylcholine, these are the names. It is the only depolarizing neuromuscular blocker in clinical use right now. It is composed of two acetylcholine molecules linked back to back through acetate methyl groups. It is a quaternary ammonium compound. So this is the structure of acetylcholine, which is composed of two acetylcholine molecules linked back to back through acetate methyl groups, and it is a quaternary ammonium compound. Now succinylcholine is a depolarizing muscle relaxant that produces depolarization, which result in desensitization of nicotinic acetylcholine receptors. It can result in inactivation of voltage gated sodium channels and increase in potassium permeability. Now the end result is failure of action potential generation and neuromuscular blockade. So initially, what does succinylcholine do? So succinylcholine initially binds to the nicotinic acetylcholine receptor. Okay, initially it will, so the nicotinic acetylcholine, okay, let me tell you a little about this receptor. Now this receptor is a pentameric structure. Okay, it is cylindrical. So it is a cylindrical pentameric structure composed of 5 subunits. Now these subunits are 2 alpha, 1 beta, 1 delta, and 1 epsilon subunit. So these make up the receptor. Okay, the nicotinic acetylcholine receptor, which can bind acetylcholine as well as succinylcholine. This nicotinic acetylcholine receptor, which is located on the muscle membrane, on the shoulder of the clefts that are found in the muscle membrane. These clefts are usually right across. These clefts are usually right across the where the nerve terminal, which this entire thing forms the where transmission occurs, forming the motor end plate. Now this receptor, like I said, 2 alpha, 2 beta, 2 alpha, 1 beta, 1 delta, 1 epsilon subunit. Now acetylcholine has to bind to both the alpha subunits basically for contraction to occur. Okay, so it has to bind to both the alpha subunits for muscle contraction to occur. So succinylcholine, since it is structurally similar to this acetylcholine, will bind to these 2 alpha subunits. So this is in a mature receptor. It will bind to these 2 alpha subunits, which will initially lead to contraction, muscle contraction. Okay. Now later on, after contraction, Acetylcholine, usually in the synaptic cleft, when this occurs, is degraded by acetylcholine esterase. So when acetylcholine binds to the receptor, as the action is occurring, this acetylcholine is degraded by this acetylcholine esterase. As a result, the depolarization stops because acetylcholine is degraded. It leaves the receptor, and the receptors can come back to their resting state, and muscle contraction stops. But with succinylcholine binds to the 2-alpha receptors, but it is not degraded by acetylcholine esterase. So, since it is not degraded by this acetylcholine esterase, it continues to bind to the nicotinic acetylcholine receptors, producing continuous depolarization. Which, because of this continuous depolarization, it leads to over here desensitization of the receptors, inactivation, I will come to this, of the sodium gated channels which are located in the clefts of the muscle membrane, because there is continuous depolarization, and voltage gated sodium channels are voltage dependent. Hence, because there is voltage continuously there, because acetylcholine binding, these channels will not close, will not return to the resting state, and there will be increase in potassium permeability. Of course, because the sodium channels are activated, the nicotinic acetylcholine receptors are activated, so there will be a continuous efflux of potassium. So the end result is failure of action potential generation and neuromuscular blockade. So coming to the mechanism of action. So depolarizing muscle relaxants, like I said previously, closely resemble acetylcholine and readily bind to acetylcholine receptors, generating a muscle action potential. Okay. Unlike acetylcholine, however, these drugs are not metabolized. Like I said, they are not metabolized by acetylcholine esterase. Okay. Whereas acetylcholine is metabolized by acetylcholine esterase. As a result, it diffuses away from the receptor, and the acetylcholine receptors, as a result, the receptors return to the resting phase. But here, succinylcholine is not metabolized by this acetylcholine esterase, and the concentration in the synaptic cleft does not fall rapidly, resulting in prolonged depolarization of the muscle end plate. This continuous end plate depolarization then leads to muscle relaxation. So there is continuous, because it is continuously bound to the muscle end plate, the depolarization is continuous, which initially causes muscle contraction, later leading to relaxation, because the receptors get desensitized. They are no longer they cannot react, and hence it causes muscle relaxation. Now, because opening of perijunctional sodium channels is time limited, sodium channels rapidly inactivate with continuous depolarization. So now, continuous end plate depolarization causes muscle relaxation because opening of the lower gate in the post-junctional sodium channels is time limited. After the initial excitation and opening, these sodium channels close and cannot reopen until the end plate repolarizes. The end plate cannot repolarize as long as the depolarizing muscle relaxant continues to bind to the acetylcholine receptors, leading to a phase 1 block. So, succinylcholine blockade is divided into phase 1 and phase 2. Okay. Now I will tell you all about these sodium receptors. Now, as I said, these sodium receptors are located on the muscle membrane. This is your nerve and this is your muscle. Okay. So these are the this is the motor end plate. Okay, where your where the uh, neurotransmission is initiated and then further leads to muscle contraction. So acetylcholine binds to the acetylcholine receptors which are located here. These sodium channels are located in these clefts over here. Okay. Now when acetylcholine, like I said, binds to acetylcholine receptors. Okay, succinylcholine is binding to the 2 alpha receptors, causing a conformational change in the channel, acetylcholine receptor channel, which leads to influx of sodium and calcium and efflux of potassium. This is a voltage generated here because of the movement of ions, and this leads to, this is the junctional membrane where the receptors are located. This voltage that is generated here causes depolarization further of the perijunctional, that is around the junctional area where the sodium channels are located. Now the sodium channel again is a transmembrane protein and it can be conceptualized to have 2 gates. Okay, one is a voltage, this is your voltage dependent gate, and this is your time dependent gate, and it exists in 3 states: resting, the active state, and the, of course, the inactive state. Okay. So now in the resting state, the basically the channel is not functioning. So the time dependent gate is open and the voltage dependent gate self-explanatory. It needs ions to move to be open, but it is closed because there is no movement of ions. The muscle is in the resting phase. Now in the active state, that is when threshold voltage depolarization is reached. That is when the acetylcholine receptor is depolarized and the same depolarization is reached with perijunctional membrane. This voltage dependent channel will open. Sodium will move through this channel. Since a time dependent gate also was open, sodium moves through this channel, right? Now, shortly, this is a time dependent gate, right? So, shortly after the upper gate opens, the time dependent gate will close and now sodium cannot move through. So, this receptor is in the inactive state. The time dependent gate is closed, the voltage dependent gate is open, but sodium cannot move through. So, there is no depolarization occurring. So, the sodium channel is in the inactive state. And then from here it returns to the, because there is no flow, the voltage channel will automatically close, time dependent will open, and it returns to the resting phase. Now succinylcholine, it binds to the acetylcholine receptors, like I said, and causes a continuous depolarization because it is not metabolized by acetylcholine esterase, unlike acetylcholine. So acetylcholine gets degraded over here because of acetylcholine esterase, but succinylcholine continues to be present because it is not degraded by acetylcholine esterase at the neuromuscular junction. So it continues to cause a depolarization over here. So this voltage gated channel will continue to be open, but this, so initially, like I said, the time dependent gate will be open when that initial depolarization comes, when succinylcholine binds to the receptors. This gate will also open, time dependent gate is open, there will be an influx of sodium, a muscle contraction will occur initially, which will be noticed as fasciculations. Okay, so that initial muscle contraction is seen as fasciculation, okay, with succinylcholine. Now this passes through, but the time dependent gate will close, but this voltage dependent gate will continue to be open because there is a continuous depolarization occurring. So the voltage So the voltage, the sodium channel will get stuck in this inactive state because succinylcholine is continuously causing depolarization at the muscle membrane. So continuous end plate depolarization causes muscle relaxation because opening of the lower gate in the post-junctional sodium channel, like I said, is time limited. Okay, I hope you all understand now. After the initial excitation and opening, because initially both the voltage gate as well as the time gate will be open, so there will be an initial excitation. The sodium channels close and cannot reopen until the end plate repolarizes. So the sodium channels has to close for the end plate to repolarize. But the end plate cannot repolarize as long as the depolarizing muscle relaxant continues to bind to the nicotinic acetylcholine receptors. This leads to a phase 1 blockage. So basically in your phase 1 blockage, the sodium channel will be in the inactive state and the membrane cannot repolarize because of the continuous depolarization, right? Because of the continuous depolarization. So at this point, the muscle membrane gets separated into 3 zones, okay? The end plate, which is depolarized by choline, that is your muscle end plate, which is depolarized by choline. The perijunctional membrane in which, so this is your muscle end plate, which is depolarized by choline. This is your perijunctional area where the sodium channels are in the inactive state. Okay, and now the rest of the muscle membrane. So the rest of the muscle membrane, the sodium channels here are in the resting phase. Now why are they here in the resting phase? Because the sodium channel here is in the inactive phase, so it is not transmitting the depolarization. So these sodium channels in the rest of the muscle membrane will be in the resting phase. So there is no muscle contraction occurring. So even if there is a burst of acetylcholine, lots of acetylcholine is released, this cannot overcome the inactivated sodium channel. Okay, so this hence it is protecting the rest of the membrane. This is known as accommodation. So even a burst of acetylcholine cannot activate this inactive and this resting sodium channels. Now coming to these extraocular muscles. So the extraocular muscles are tonic muscles. Okay. So extraocular muscles are tonic muscles, that is, they are multiply innervated and chemically excitable along most of its surface. So now what happens in usually one nerve innervates, one nerve comes from the lateral horn of the spinal cord, yeah, ventral horn of the spinal cord, I'm sorry, and the nerve branches terminally as it approaches the muscle, and it will, in the muscle, one will innervate each muscle fiber. Okay. So each branch will innervate one muscle fiber. This entire thing is known as your motor unit. Okay. Now, but the extraocular muscles, they are tonic muscles, they are multiply innervated. So one muscle fiber can be innervated by many nerve terminals, okay, and they are chemically excitable along most of its surface. Now these extraocular muscles express both mature and immature receptors. Now what are these mature and immature receptors? Like I told you, the nicotinic acetylcholine receptors are pentameric structure. Adult is composed of 2 alpha 1 beta, 1 delta, and 1 epsilon subunit. Now your immature receptor, instead of the epsilon subunit, there will be a gamma subunit. So this is usually expressed during fetal life and during denervation. Okay? That is when there is sepsis, burns, or upper motor neuron, lower motor neuron lesions. That time these receptors get expressed along with mature receptors. But in the fetal life, they are always present. And as the fetus matures, the part of the maturation of neuromuscular junction is conversion of gamma to epsilon. So, but the extraocular muscles, these extraocular muscles, they express both the mature and the immature receptors. So accommodation does not occur. What I explained earlier, accommodation does not occur. And these muscles can, because the immature receptors are also present, and they readily bind succinylcholine. They bind succinylcholine more rapidly than the mature receptors. And in these muscles, accommodation will not occur, and they can undergo sustained contracture in the presence of succinylcholine. Now, like I said, what does accommodation do? Accommodation prevents the rest of the muscle. It actually protects the rest of the muscle from contracting because the sodium channels are in the inactivated state. But over here, even though the sodium channels are inactivated state, because of the multiple innervation, these muscles do not undergo accommodation. So if there is succinylcholine can go on binding, and they can cause sustained, since it is multiply innervated, it causes sustained contraction in the presence of succinylcholine. Thus the tension a tension develops in the eye, which forces the eye against the orbit and accounts for the rise in the intraocular pressure. So now, like I said, succinylcholine, it can cause receptor desensitization and channel blockade. Okay. Now desensitization, they are not sensitive to the channel opening actions of agonists. That is when a receptor is desensitized, it is not sensitive. Whatever agonist binds, it will not react to that agonist. So here, on these desensitized receptors, agonist and antagonist can both bind. Okay, like you can see here, the agonist and antagonist can both bind. So an agonist will bind, there will be no reaction, there will be no muscle contraction. These are resistant receptors. Okay, this is because of continuous depolarization. These receptors, the acetylcholine receptors, can go into a state of desensitization. Okay, how does this desensitization occur? Is because of phosphorylation of a tyrosine unit, which is present in, so the tyrosine unit is a receptor protein that is present in the nicotinic acetylcholine receptor. So phosphorylation of one tyrosine unit occurs, which leads to desensitization of the receptor. Now it is said that this desensitization of receptor is more part of the phase 2 block of succinylcholine. Like I said, succinylcholine consists of 2 blocks, phase 1 and phase 2 block. So desensitization is more seen with the phase 2 block. In the phase 1 block, the sodium channels are blocked in the inactive state, preventing muscle contraction because the sodium channels beyond the perijunctional membrane are in the resting state. Now, channel closed. So like I said, some drugs can involve 2 clinically important reactions. One is receptor desensitization, the other is channel block. Now, channel block, there are 2 types, closed and open channel block. Closed channel block, certain drugs will just occupy the mouth of the channel and block. There can be no transmission of impulse. Whereas open channel block, a drug molecule enters, like the agonist can enter channel opened by acetylcholine but doesn't penetrate all the way through, hence blocking the channel. In these, the normal flow of ions through the receptor is impaired, preventing depolarization. So now these 2 mechanisms, this is the channel block and the desensitization block, is mostly seen with phase 2 block. Now like I said, phases of block, it is composed of phase 1 and phase 2 block. Phase 1, the perijunctional sodium channel cannot reopen until the end plate repolarizes. The end plate cannot repolarize as long as the depolarizing muscle relaxin continues to bind to acetylcholine receptors, hence phase 1 block. So sodium channel receptors are stuck in the inactive phase. They cannot reopen because as end plate has to repolarize. End plate cannot repolarize because succinylcholine is binding to the acetylcholine receptor. Phase 2 block, this is generally after a long period. So this is generally seen when you give the second dose of succinylcholine or during infusions of succinylcholine, which are very rarely used, but yes. So after a period of time, the prolonged end plate depolarization can cause this poorly understood block. It is not well understood in the acetylcholine receptors, that is known as the phase 2 block. Desensitization is said to be one explanation and channel block another. So like I said, phase 2 block is because of continuous exposure to the drug, that is, it can be due to infusion or due to the second dose of the drug. Action is on the prejunctional neuronal acetylcholine receptors. So whatever I told you about that pentameric structure and all those, that is on the postjunctional muscle membrane. On the prejunctional membrane also there are receptors, that is 3 alpha and 2 beta receptors. This is also a pentameric structure, cylindrical, located on the neuronal membrane, nerve membrane. These receptors are generally responsible for release of acetylcholine by a positive feedback mechanism. So whenever acetylcholine is released, these receptors get activated and they release more acetylcholine. So succinylcholine as such cannot bind to these receptors, okay? But when phase 2 block, that is when there's continuous exposure of the drug, excess of the drug, it will bind to these neuronal receptors, and it leads to a mechanism known as fade, that is on neuromuscular monitoring, which is, this fade will not, this comes in neuromuscular monitoring, which I will be dealing with later. But just remember this, it leads to a mechanism known as fade on neuromuscular monitoring. That is when a monitor is attached to the one of the nerves to test the blockade of the nerve. A response such as fade will be seen, something like this decreasing order. Okay, on stimulation of the nerve. This is an evoked response that will be seen on the monitor of the neuromuscular monitor. This response is never seen with succinylcholine. It is usually just a normal block that you see with succinylcholine. But when phase 2 is occurring, when the succinylcholine molecules bind to these prejunctional neuronal acetylcholine receptors, it produces fade. Now, other factors like electrolyte imbalance due to potassium efflux can also disrupt the membrane, leading to phase 2 block. So because of continuous drug exposure, there will be a lot of efflux of potassium leading to this phase 2 block. So the phase 2 block depends on the duration of exposure of the drug use, the concentration of the drug use, the type of muscle, and other anesthetic agents. Now, breakdown of succinylcholine takes place in 2 stages. Both are mediated by this enzyme known as pseudocholine esterase. Okay, pseudocholine esterase or butyrylcholine esterase. Also, it causes rapid hydrolysis. Succinylcholine breaks into succinyl monocholine and choline. Succinyl monocholine further breaks into succinic acid and choline. Now, the succinylcholine and monocholine both have similar agonistic action like succinylcholine, but much weaker. Okay. Now, choline, it does not bind to mature receptors, but this choline binds to the immature receptors. It has a high affinity to the immature receptors. As a result, it can cause high degree of block in these immature receptors. So that's what I'm saying. So in the extraocular muscles, you have succinylcholine as well as choline acting on these receptors throughout the muscle membrane, since there is no accommodation occurring. As a result, it leads to tonic contracture. The short duration of succinylcholine is due to rapid hydrolysis by butyrylcholine esterase or pseudocholine esterase, such that only 10% of the administered drug reaches the neuromuscular junction. So at the neuromuscular junction, there is very little butyrylcholine esterase present. Okay. The action of succinylcholine is actually terminated by diffusion away from the neuromuscular junction. So butyrylcholine esterase is basically present only in the plasma. So it hydrolyzes the succinylcholine in the plasma. So as the plasma concentration of succinylcholine decreases, then there is termination of action at the neuromuscular junction, because along the concentration gradient, the succinylcholine diffuses away from the neuromuscular junction into the plasma, where it is degraded by this butyrylcholine esterase. Hence, it influences the onset and duration of action of succinylcholine by controlling the rate at which the drug is hydrolyzed before it reaches and after it leaves the neuromuscular junction. So, before it reaches and after it leaves the neuromuscular junction. It has nothing to do at the neuromuscular junction. Now, pharmacokinetic and pharmacodynamics of succinylcholine. Okay, two important characteristics. It produces intense and rapid paralysis, very rapid paralysis, and the effects are likely to wane before a pre-oxygenated patient becomes hypoxic. So basically, when we give a muscle relaxant, the patient is basically hypoxic. There is no oxygen being delivered because the muscles are all paralyzed. So the patient comes out of this very quickly, as you will see further. So it is a quaternary ammonium compound, highly ionized and water soluble with less lipid solubility. It has a rapid onset of action, which is around 30 to 60 seconds following an intravenous injection, and short duration of action, 3 to 5 minutes, because butyrylcholine esterase degrades it in the plasma. Only 10% reaches first of all to the neuromuscular junction. It is quickly degraded in the plasma, so it dissociates away from the neuromuscular junction. The dose is generally 1 milligram per kg for tracheal intubation. So these characteristics make succinylcholine a very attractive drug for providing skeletal muscle relaxation to facilitate tracheal intubation. Tracheal intubation has to be performed within 15 seconds. So this drug acts within 30 to 60 seconds. The duration of action is very short, just around 3 to 5 minutes. So the patient, even if you cannot intubate, the patient will come out of this drug in 3 to 5 minutes and you will start breathing again. So it is a safety margin for the anesthesiologist. So succinylcholine has an elimination half-life of 47 seconds. Dose of succinylcholine causing 95% suppression of twitch height is approximately 9.3 milligram per kg. That is your ED95. So 95% suppression of your twitch height basically is it causes paralysis in 95% of these subjects. So basically, when neuromuscular monitoring is done, when a muscle is stimulated, there will be a twitch, but this twitch is suppressed in 95% of the subjects with a dose of 0.3 milligram per kg. The dose for tracheal intubation is usually 2 to 3 times the ED95, which is 1 milligram per kg. Patients with normal butyrylcholine esterase activity, the time to recovery to 90% muscle strength ranges from 9 to 3 minutes. So with normal plasma choline esterase activity, within 9 to 3 minutes of giving the succinylcholine, the patient comes back to normal. This is important, this 9 to 3 minutes. Now, what are the factors affecting this butyrylcholine esterase? So it is synthesized, basically it is synthesized in the liver. It is synthesized in the liver. It is found in plasma. The elimination half-life of plasma choline esterase is 8 to 16 hours. Okay, it is synthesized in the liver, found in the plasma. It is responsible for metabolism of succinylcholine, mivacurium, and these are some of the local anesthetics: mivacurium, procaine, cloprocaine, tetracaine. The activity of enzyme refers, this is important, refers to the number of substrate molecules hydrolyzed per unit of time, okay, which is often expressed in international units. So it is the number of succinylcholine molecules that it hydrolyzes per unit of time. That describes the activity of the enzyme, which is mainly occurring in the plasma. Now, the factors that lower butyrylcholine esterase activity, these are some of the factors like advanced liver disease, advanced age, malnutrition, pregnancy, burns, some chemotherapeutic drugs, cytotoxic drugs, anticholinesterase drugs, bambuterol. These are some of the factors that lower butyrylcholine esterase activity. Now, atypical pseudocholinesterase, the structure of it is basically gene determined, the butyrylcholinesterase structure. So, there can be the heterozygous or the homozygous gene. Sorry, heterozygous blocks for about 20 to 30 minutes, whereas the homozygous gene produces a longer blockade of 4 to 8 hours. Now, the measurement of atypical pseudocholinesterase. So, there are two ways it can be measured, quantitative and qualitatively. So, quantitatively, it is determined in the lab per unit ml. That is influenced by the comorbidities, medication, genotype. But qualitatively is this Debukane number. This is actually the major factor how you can determine the activity of these atypical pseudocholinesterase enzyme. So Debukane, Debukane inhibits normal pseudocholinesterase much better than it inhibits abnormal. Okay, so the normal enzyme is inhibited 80%, whereas the abnormal enzyme only 20%. So Debukane is actually a local anesthetic which inhibits normal pseudocholinesterase activity. Now the percentage of inhibition of pseudocholinesterase activity is known as Debukane number. So the amount that Debukane can inhibit pseudocholinesterase activity is known as Debukane number, which actually indicates the amount of active normal pseudocholinesterase. Now coming to the side effects of succinylcholine, cardiovascular. So succinylcholine acts on the cholinergic acetylcholine receptors in addition to the nicotinic receptors, muscarinic receptors in the neuromuscular junction. So it stimulates the parasympathetic as well as the parts of the sympathetic system like the sympathetic ganglia, adrenal medulla, sweat glands. So what does this lead to? So this stimulation produces a variety of effects. So the nicotinic receptors in the parasympathetic and sympathetic ganglia, it activates, and also it activates the muscarinic receptors in the SA node of the heart, leading to a complex effect. So succinylcholine binds to the nicotinic receptors in the neuromuscular junction as well as in the parasympathetic and sympathetic ganglia and to the muscarinic receptors in the SA node. So it leads to an increase or decrease of blood pressure and heart rate. So low doses of succinylcholine can produce negative chronotropic and inotropic effect, whereas higher doses usually increase the heart rate and contractility and elevate the circulating catecholamines. So in low doses, it has a negative chronotropic and inotropic effect, whereas in higher doses, it increases the rate and contractility and increases catecholamines. Hence, it can increase the BP or decrease the BP and heart rate. Now, sinus bradycardia, it is more often seen after a second dose of succinylcholine. So it is said that maybe it is more because the hydrolysis products sensitize the SA node of the heart. So stimulation of the cardiac muscarinic receptors in the sinus node, the mechanism might be due to the stimulation of these muscarinic receptors in the sinus node, ganglionic stimulation, or direct myocardial stimulation. Okay, these all can be factors which are responsible for causing sinus bradycardia. This can be prevented by prior administration of non-depolarizing muscle relaxants. So junctional rhythms. So stimulation of the muscarinic receptors in the sinus node, suppressing the sinus mechanism. This, because of the stimulation of the muscarinic receptors in the SA node, it suppresses the sinus mechanism, which allows emergence of the AV node as the pacemaker. Okay, again, the incidence is greater after the second dose. Ventricular dysrhythmias. So drugs that lower the ventricular threshold, like inhalation anesthetics like halothane, bradycardia, which is seen due to succinylcholine, the second dose, or AV nodal slowing, lead to release of potassium, and again release of potassium from the skeletal muscle because of succinylcholine causes release of potassium as a result of depolarizing action of the drug. These all can lead to ventricular dysrhythmias. Now, hyperkalemia. So in normal individuals, it is a normal phenomenon that succinylcholine releases 0.5 milliequivalent. Release of potassium in healthy individuals occurs. Patients with renal failure they are not more susceptible. They are no more. That is, they are not susceptible to succinylcholine induced hyperkalemia. But if usually patients with renal failure will have hyperkalemia because of kidney dysfunction, so this succinylcholine will actually add to that. These are some of the conditions causing susceptibility to succinylcholine induced hyperkalemia. As you can see in burns, massive trauma, basically in denervation injuries, polyneuropathy, head injury, shock, sepsis, encephalitis, neuropathies like Guillain-Barre, tetanus, Parkinson's disease. So what is the mechanism of hyperkalemia? So like I said, these denervation injuries of the spinal cord or large burn, this immature isoform of acetylcholine receptors, that is the gamma receptor, gets expressed and the alpha 7 receptor get expressed inside and outside the neuromuscular junction. This is known as upregulation of the receptors. The succinylcholine is very sensitive, like I said previously, to immature receptors, which results in excessive potassium release because succinylcholine is binding to so many receptors. There is a lot of efflux of potassium. So this cannot reliably, so most of the complications of succinylcholine can be prevented by pre-treatment with a non-depolarizing agent like vecuronium. I will be talking about that in the class where I deal with non-depolarizers. So the risk of hyperkalemia usually peaks 7 to 10 days following injury, and it is minimal in the first 2 days after an injury. So this is showing, this is a diagram which is showing the upregulation of that is see, usually the mature receptors are present only at the neuromuscular junction. There are no receptors present over here, but in a denervated muscle the receptors are present all along, mature as well as immature are present all along the muscle. Increased intraocular pressure, like I explained about the extraocular muscles, it peaks 2 to 4 minutes after administration and returns to normal by about 6 minutes. It is due to contraction of the tonic myofibrils and transient dilatation of choroidal blood vessels. Hence, because of this increase in intraocular pressure, succinylcholine, this is very important, is not used in open eye injury. The studies show that prior administration of small dose of a non-depolarizing drug can prevent this, but it is still preferably not used. Increased intragastric pressure. Now it is said that because of the fasciculation, so succinylcholine, I told you, causes that initial contraction which can be seen as fasciculations. So these fasciculations are known to cause the cause of increased abdominal skeletal muscle tension, which could lead to the increased intragastric pressure. However, this pressure does not exceed the barrier pressure, which is 28 centimeters of water. So it does not increases, hence it does not predispose to regurgitation. Again, prior administration of non-depolarizing can prevent this. Also because of the increase in the vagal tone is also because of the action on the SA node, the stimulation of the SA node. Hence the increase in the vagal tone also can lead to the increased intragastric pressure. Also, there can be an increased intracranial pressure is also another side effect. Now, myalgias again are secondary to the muscle damage caused by succinylcholine induced fasciculation. Other hypotheses are there might be a role of prostaglandins, cyclooxygenases, but is not all proven. So pre-treatment with, it said that pre-treatment with prostaglandins, muscle relaxants, local anesthetics, NSAIDs, or non-depolarizing agents can prevent this. So generally, a small dose of this non-depolarizing agent, if it is given before giving succinylcholine, you can prevent this myalgia, which is induced by muscle damage due to fasciculations. Also, masseter spasm can occur. This can cause confusion with malignant hypothermia, because malignant hypothermia is characterized by masseter spasm. Now, clinical uses. So bolus, 1 milligram per kg, like I said, can facilitate intubations, prevent, it is used for electroconvulsive therapy, since it is a short procedure, and because the patient requires to get up quickly, it is a very short procedure of about 10 minutes. So because the recovery time within 9 to 13 minutes, the patients come out of succinylcholine, hence it is used. And for, like I said, short surgical procedures. And also the small succinylcholine is used to break laryngospasm. So when laryngospasm occurs, a very dangerous way, the vocal cords adduct, it cannot be broken. So first you have to give 100% oxygen. There are a lot of methods. You have to give positive pressure ventilation. The last resort is succinylcholine, because it will immediately relax it and break the spasm. So intermittent doses can be given for short surgical procedures. You know, if they're extending, if a short procedure is extending for too long, you can give an intermittent IV dose, but it is not recommended, as second doses are known to cause a phase 2 block, and then phase 2 blocks can be very prolonged, they're very poorly understood, and it is very dangerous. So not more than, only one half of the previous dose should be given, and it is not practical for more than 30 minutes. Okay guys, so this is the end of my class. I will be summarizing it now briefly for you all. So basically, succinylcholine is a depolarizing muscle relaxant. It is has an agonistic action at the neuromuscular junction. That is, it is very similar to acetylcholine, and it causes muscle contraction initially, followed by relaxation. So it binds to the nicotinic acetylcholine receptors on the muscle membrane. It causes depolarization, but because it is not metabolized by acetylcholine esterase, it continues to bind to the nicotinic acetylcholine receptors, causing a sustained depolarization. This sustained depolarization then causes the sodium channels to be blocked in the inactive state, and the rest of the sodium channels in the perijunctional membrane will be in the inactive state, and in the rest of the muscle membrane in the resting phase. This is known as accommodation, and it prevents muscle contraction. And the muscle, so for the muscle to contract, the end plate has to repolarize, but the end plate cannot repolarize because succinylcholine is continuously binding to the acetylcholine receptor, causing depolarization. Then the second part is the phase 2 block. The phase 2 block usually occurs depends on the dose of the drug, the duration of the administration of the drug, the presence of other anesthetic agents, and other anesthetic agents and drugs. And it is said that it is because of can be because of desensitization of the receptors, or because of channel blockade. During this, it is said to occur because of action of succinylcholine on the pre-junctional acetylcholine receptors, which are located on the neuronal membrane. Because of stimulation of these receptors, it leads to a phase 2 block. Now, the succinylcholine, 1 milligram per kg is the intubating dose. It is very short acting drug, because it is degraded by pseudoplasma choline esterase or butyrylcholine esterase, which is found in the plasma. Only 10% of the drug reaches the neuromuscular junction, because most of it is degraded in the plasma. And as the plasma concentration decreases, the concentration at the neuromuscular junction also decreases, and the action is terminated, usually within 9 to 13 minutes with normal pseudocholinesterase activity. If there is abnormal pseudocholinesterase present, then the action can be prolonged. To know the activity of pseudocholinesterase, we have the Debukane number, which indicates an amount of active pseudocholinesterase. It degrades. Debukane is a local anesthetic which actually degrades normal pseudocholinesterase. So it degrades normal pseudocholinesterase 80% and abnormal pseudocholinesterase only 20%. So the two types of abnormal pseudocholinesterase are the homozygous and the heterozygous type of abnormal pseudocholinesterase. Now, succinylcholine, adverse effects are on the cardiac effects. It binds to the SA node. It can cause bradycardia. It binds to the muscarinic receptors on the cardiac muscarinic receptors on the SA node. It binds to the cholinergic receptors on the sympathetic, nicotinic cholinergic receptors on the sympathetic and parasympathetic system. Hence, it can cause increase or decrease of blood pressure and heart rate. Then it can cause an increase in intraocular pressure, hence it is not used in open globe injuries. It can cause an increase in intraocular pressure, hence it is not used in neurosurgery cases with traumatic neurosurgery, head injury cases. It can cause an increase in intragastric pressure, but it does not usually cross the pressure which leads to regurgitation. It can cause, it causes fasciculations which can lead to myalgias, and it can cause junctional rhythms and as well as nodal rhythms. It is, the uses are basically for tracheal intubation and for short duration surgeries like electroconvulsive therapy. You can give a repeat dose, but only for the only 2 doses, and you have to give half the dose, but it is not advised as it leads to a phase 2 block. So guys, this was about my class. My next class, that's it for my class. My next class will be on non-depolarizing muscle relaxants. Do hit the bell icon for notifications, and please subscribe, guys. You will get 10% discount on my code. Do subscribe for the 12 and 24 month subscription. See you all during my next class. Thank you.